Good afternoon, everyone. And I just want to say welcome back to those of you who were with us this morning for the first session of our symposium. And welcome to those that are joining us for the first time today. And we've got a really good one again this afternoon. And I just want to let you guys know that this event is being recorded and will be made available on the Research Ethics BC website at a future date. For those of you who were not with us in the morning session, we had the honor of having Elders Grouse and Pamela Barnes provide us with perspective on why we all should acknowledge the traditional territories from which we join this virtual Zoom environment. I am grateful to be joining you today from the unceded territories of the Coast Salish people, namely the Musqueam, Squamish, and Tsleil-Waututh nations. I invite you now to please add your own acknowledgements in the chat function. I hope everyone has also taken the opportunity to review the bios of our panelists this afternoon. If you have not, Paola will very shortly add a link in the chat, and the link is to the symposium website, and it'll allow you to take a look at their bios and follow along if you haven't had a chance to do so already. And before we get started, I'd just like to encourage everyone to use the chat function to connect with others during the session. If you have a question, we have chosen to use the Slido, and the moderator will be using Slido to facilitate the question and answers portion of this session. If you have a question for the speaker, please go to the link that will be populated every once in a while by Hannah, and she'll put it in the chat function, and then you can add in your questions in Slido, and they can get ranked, and you can put a thumbs up on those that you think are really important to prioritize. And now it's my pleasure to turn everything over to our moderator for this session today. Our moderator is Caron Gelmon, and Caron is a well-known figure in research ethics in the province, and a professor of medicine at UBC and a medical oncologist with BC Cancer. She's also the chair of the BC Cancer Research Ethics Board and a fellow of the Canadian Academy of Health Sciences. Thank you very much, Caron, and thank you for joining us today and agreeing to be a moderator for this session. I'll now turn it over to you.
Thanks very much, Terry, and I'd like to thank everyone who's joined. I'd particularly like to thank the organizers of this meeting for inviting us to participate in this session. And I'd like to draw attention to Jessica Gagliardi, who is one of the research officers at the UBC BC Cancer Research Ethics Office, and she's really put this together. So thanks, Jess. We've got a really interesting forum, I think, and the title of the forum is The Ethics of Real-World Genomics in Practice. And we're going to talk about, obviously, real-world genomics in research with a focus on research, but also straddle into the clinic, because I think increasingly we're seeing that clinical care and research overlap, and it's important that we acknowledge that. The speakers are all going to speak first. We've got 5 great speakers, and we're going to have the speakers each present a little bit about this topic, about a 10-minute talk or so, but we know that nobody ever is exactly 10 minutes. And then we're going to throw it open to questions. So if you've got questions, please put them into the chat, into Slido. We'll then use those questions. Later on, we might be able to have you raise your hands or pop up or give your question verbally as well, but we'll try to do it that way. So hold on to your questions. I think that'll allow all of the speakers to get their points of view forward. I'm not going to introduce each speaker as they go along. As Terry said, their bios are in the website. I'm going to introduce all 5 of them now in the order they're going to speak. And I'm going to ask them just to start up after the last person's finished and to start their talk. And that might sort of create a bit of a seamless Zoom. You know, we all know that Zoom works increasingly well as we get more used to it, but that sort of seems the best way to do it. So I'd like to introduce the speakers right now. Claudia Nichols is our patient partner, and she's going to talk about her story and also put it into the context of other patients and participant stories. And she's dynamic. I think you're going to hear a great talk from her. After Claudia, Dr. Howard Lim, who's a clinical associate professor of medicine at University of British Columbia, is going to speak. He's a medical oncologist. He's been very involved in the POG, the Personal Onco-Genomics program, as well as lots of clinical trials around GI cancer, and very involved in all the issues around the right to know, incidental findings, what we need to discuss around this. And I think you'll get a lot from his talk. Sophie's son, who's a clinical associate professor at UBC and a medical oncologist at BC Cancer, is going to speak next. And Sophie co-leads the Hereditary Cancer program at BC Cancer with Intan Schrader. And Sophie really knows about genomics, about genetics. Her first master's before her medical school was in genomics. And so she's been living genomics for a long time, including having 3 kids with genomics, so that she really knows the practical issues. And we're going to then have Jennifer Nuck. Jennifer is a genetic counselor with the Hereditary Cancer Program and a clinical coordinator, and she's dealing with patients with unaffected persons with genomic inherited mutations, as well as with persons with cancer, and has incredible experience in the communication of this whole area to persons and the sensitivities and psychological and sociological impact of the communication. And we're going to finish up with Dr. Nadine Caron, who is a very well-known speaker. Nadine is an associate professor at the Northern Medical Program at UNBC, and is very, very involved in the Aboriginal health from UBC, in communication with patients, in research, in tumor banks, and that whole gamut that straddles the genomics. So we've got a great panel, and I'm going to mute myself now and hand it over to Claudia to start this great session. Thank you, all of you.
Good afternoon, everybody. My name is Claudia Pavao, and I'm excited to have this opportunity to share my story today. I'll be telling you a little bit about my cancer journey, as well as living with the Lynch syndrome. I'm a wife for 13 years. My husband's put up with me, and I have 2 beautiful kids. Elizabeth is 12, and Christopher just had his 10th birthday on Tuesday. Definitely not a quiet birthday this year, that's for sure. Laser tag was very loud. I'm a psychiatric nurse. I've been doing this for over 20 years now. It's an exciting job. Every day is a bit different. It's not easy, but I look forward to going to work every day. It's actually a break when I get to go to work. So when I was pregnant with Christopher, I noticed near the end of my pregnancy that there was a little bit of blood in my stool. And my midwife and I just figured it was probably hemorrhoids because I was pregnant. But after Christopher was born, it got a lot worse, much worse actually. I hadn't really noticed any other symptoms of colorectal cancer, but my other possible symptoms were probably masked by my pregnancy, like bloating, upset stomach, that kind of stuff. So I also noticed I was very tired, but also I was a new mom with a newborn baby and a 3-year-old toddler running around. So I just kind of chopped it up to that. Eventually, I went to the doctor and I was tested, and of course, they found blood in my stool. And so I was put on the wait list to have a colonoscopy. So 11 months later, I got scheduled. It took 11 months because I was seemingly, a healthy young 33-year-old. That wasn't the case. So February 14th, 2013, the day that my life changed forever. I can't even remember what I had for lunch yesterday, but that day is ingrained in my brain. It's crystal clear. I went in for my test, and in the room, it was a small room. There was the person that was, giving their information and having an IV started. And then there was a post-endoscopy patient. And then in the far corner, there was the sleeping post-colonoscopy patient. And then there was the waking up colonoscopy patient in front. That was definitely the most interesting patient, the one that was waking up. So I kind of watched a few people rotate through this process, and then it was my turn. So I went in for the test. They put me to sleep, and then I woke up in the recovery room. I remember asking the nurses if it was normal to have that much blood after the test, and they really couldn't even look me in the eye. And then I was put in a different spot than I saw everyone else going. And they drew blood and they just said, oh, it's just a regular normal panel. I remember I sent a friend who worked at the hospital that I work at a message jokingly saying I must be dying because nobody else had to get blood work. And then the doctor wanted to wait for my husband to come to give me my diagnosis. So I just kind of figured that I had colitis or something like that. Cancer wasn't even in the radar for me at that point. I was too young. I was only 33. So that afternoon, Dr. Siegel, who performed my colonoscopy, sat my husband and I down in a quiet corner, and he said, "You have a tumor." I didn't hear anything after that. He was a very kind man, though, but the emotional roller coaster that happened after this was overwhelming. How could this possibly be happening to me? I was 33. I was in my prime. I'm a new mom. So all of the different scenarios that could possibly happen played through my mind over and over. The anxiety, the shock, the sadness, the anger I felt. I remember having to tell my mom that her own daughter had cancer. My dad had recently passed away a year and a half prior to this, so we were also processing and grieving this. It just felt like it was too much for me to handle. So I sat on the stairs and I said to my mom, "I have cancer." And she looked at me and she said, "You've got this. You're going to be all right." She's my rock. So 10 days after my diagnosis, I had a CT scan, but that was it. So 10 full days of me not knowing what was going on in my body. My anxiety was so high. My granny had an appointment because she also was going through cancer, not Lynch related, but she had an appointment on February 24th. So I snuck in with her to her appointment. And at the end of her appointment, she said to her oncologist, Dr. Lim, "Can you please take care of my granddaughter?" So of course we're all crying. Well, not Dr. Lim. He wasn't crying, but the rest of us in the room were crying. So he became my oncologist that day. He's a sucker. He's been stuck with me for the past 8 years, and these genes aren't changing, so he's going to be stuck with me till the end of his career. So fast forward to my treatment. I completed 25 days of radiation with a bonus 3. In conjunction with this, I did oral chemo. And it was quite amazing because about 7 to 10 days after I started, the bleeding stopped. So I knew that the treatment was working. We waited for 8 weeks after the treatment, and this gave time for the tumor to shrink. And then I had my surgery. And that's a whole nother story. But what I can tell you about it is that my surgeon, Dr. Caron, is amazing. And also that not eating for 8 days was terrible. I had to not eat for 8 days, but that first piece of toast was amazing. So once I received the surgery, or I recovered from the surgery about 6 weeks later, I did 4 more months of chemotherapy. And during this period, I had lots of appointments with Dr. Lim. And it was during one of these appointments that he told me that I tested positive for the Lynch syndrome. And this felt like a massive setback, and it almost felt like he was telling me that I had cancer again. The first thought that came to my mind was, what if the kids have it? They have a 50% chance of having it, but they also have a 50% chance of not having it. You know, if they do have it, how will that affect their lives? How will they make different decisions in their lives? If my daughter has it, will she opt for a hysterectomy? Will she still have the opportunity to have children if she wants? I was flooded with anxiety and questions. So the next step was to see a genetic counselor. So I saw Mary Jane to the rescue. So I call her MJ. She's wonderful and so informative. She explained to me what the Lynch syndrome was and what my optional steps were moving forward in terms of informing my family about it and so forth. She was extremely helpful. I was fully on board with giving my family all of the info that they needed to make an informed decision to get tested or not to get tested. Honestly, though, knowledge is power. It's not like Alzheimer's, where early screening for Alzheimer's won't change the trajectory of it. Early detection of the Lynch syndrome could potentially have a huge impact on your trajectory. Hence, knowledge is power. So I signed a consent form, which gave Mary Jane permission to share my medical history pertaining to the Lynch syndrome with my family. MJ was very helpful with putting together packages to send to my family nearby and as far as England, where my dad's whole side of the family lives. It was up for me, though, to inform them about the Lynch syndrome and what it is and their options to get tested. With the new and super scary diagnosis, this was a really hard task for me for a number of reasons. I didn't fully understand and grasp exactly what this was at first. So when my family had questions, I couldn't necessarily answer them. I too was also trying to come to terms with this diagnosis and understand what it meant for myself and my family. If it had been up to me, I definitely would have had the experts reach out to my family instead of me giving them the information. It was a high stress time in my life and I had a lot on my plate. That being said though, I've had nothing but amazing care from BC Cancer, and I have the very best team a patient could ask for. The question that came up for me when I was writing this out was, what if I didn't want to tell my family? That's obviously not the case, but what are my rights around that? What are their rights around that? What happens if I'm adopted and don't know my biological family? What if I'm estranged from my family? How are these people going to get the information? Just a little food for thought. So once I settled in with the diagnosis, I decided to have a full hysterectomy. My ovaries were damaged by the previous radiation and I couldn't have any more children. And I knew that I was at pretty high risk for possibly getting uterine and ovarian cancer. Menopause at 34, definitely not ideal, but much better than the possibility of getting cancer in these areas. All I have to do now is I have estrogen cream that I slap on my arm every morning. I think that my symptoms are under control, but that's probably, you'd have to ask my husband and kids about that. I'm the first and only member of my family to test positive for the Lynch syndrome. Apparently I need to buy a lottery ticket. When the children are old enough, when they're 19, they will have the opportunity to get tested. What I have to keep telling myself is that even if they're positive, that doesn't mean that they're going to get cancer. It just means that they're going to have access to screening much earlier than myself. So theoretically, if they had cancer, then they would detect it early. Now that I've had to live with this diagnosis for 8 years, for the most part, it's on the back burner. I still have times of high anxiety and worry for sure, but definitely less so than before. I can usually manage to work through it. When I can't work through it, I usually send Dr. Lim a ridiculous email about all of my nonsensical fears, about my sore toe or my sore finger. I must have cancer. There was one time I came home from a stagette in Naramata where there was a lot of wine enjoyed. And of course, because I had so much wine, I had a canker sore. Well, I went to the dentist and I said, I've got a tongue tumor, because that's just automatically where my brain goes. But Dr. Lim's amazing, and he knows when he needs to give me a call just to slow down my nerves. But at the end of the day, there's nothing I can do to change the fact that I have the Lynch syndrome and that my children may have it too, because you can't change genes. But what I can do is I can be proactive with screening. I can continue to talk about it and raise awareness, and I can continue to advocate for patients. So although cancer sort of sucked, having the Lynch syndrome also isn't great. It's not all bad. So many positive things have come from having it. The people that I've come into my life and the experiences that I've had and the opportunities to volunteer and be a patient advocate and peer mentor have been amazing. I feel blessed for that. I could go on and on and on about the people and the connections that I've made, but I won't, because there isn't enough time. I only have 10 minutes. So that's kind of like the Coles notes of my story and having the Lynch syndrome. Thank you for giving me the opportunity to share my story today. I've spared you the details of what it entails to have screening done, because nobody needs to know about the joys of colonoscopy prep. And a massive thank you to BC Cancer Foundation for their incredible care, and to all of the deserving clients.
Thank you, Claudia. Thank you very much. That's incredibly moving, and thank you so much for sharing.
Thanks, Claudia. So I'm just going to share my screen, and while I'm doing that, I want to also say it's been a real pleasure knowing you and being your oncologist. Claudia also has this unique skill to fire me an email when I'm actually not in the office, and routinely, I think probably 90% of the time, you'll get my out of office reply. That's not on purpose. I haven't set it up that way, although there are days I wonder if I have set it up that way for you. But so Sophie and I are going to really, we're tag teaming and we put our slides together. So we're going to talk about the evolution of ethics within genomics. And really, we're part of the Personalized Oncogenomics program. It's great that a lot of people at Genome Science Center have also been featured, and here's some of the artwork that's been done that's now on the cover of Science. Well, Sophie and I want to acknowledge that we both worked and live on the traditional and ancestral territories of Musqueam, Squamish, and the Tsleil-Waututh nations. Here are our disclosures. I've received honorarium for consultancy work with various pharmaceutical companies, as well as I'm an investigator on various clinical trials here at BC Cancer. Sophie also equally has also done various honorarium from consultancy work with pharmaceutical companies as well. Oops. And where we're at really is what we're seeing now with the advent of genomics is we're turning tumor sites into different types of and smaller subsets of genomically based treatments. So here in case of breast cancer, we can now have subsets of breast cancer where you may have a BRCA positive or a PI3 kinase positive breast cancer. And now we have targeted treatments to really select out these subsets to see who's going to respond to these various treatments. So really coming up with personalized care. But as we're doing genomic testing, this has led to more of a opening up the box of when you have more information, how do you deal with the information for the patients as well? And this is part of a lot of the personalized or the population-based personalized oncology programs that we have here at BC Cancer. So not only do we have our personalized onco-genomics program, but we have our clinical testing program or our onco panel. We have ctDNA trials that are going on. And so this is really funneling into our clinical trials, and we have collaborative research, not only with genomics and hereditary cancer programs, but our social scientists, our genomics research center, and genome science center. So this is all meant to be collaborative so that we can all work together to figure out how do we deal with this evolving information. And really a lot of this is coming to the different testing approaches about how much is enough. So we can see that at the very beginning, it was just really simple PCR, just looking at hotspots, and then moving on to exomes, whole, and then we moved on to whole genome, and then we added in the transcriptome. And as you can see, as we go along and we're getting more information, there's increasing complexity, increasing information, and then that also leads to, with the increasing information, complexity with respect to the ethical scenarios. How do we deal with certain parts of the information? And as Claudia even expressed, how do we now deliver that information to patients and even patients' families? And this has really led to an evolution of ethical issues over time. So POG really started almost 10 years ago. This was back in 2011. It always works out because POG started the year my son was born. So that's when we created it, and then I went on pat leave. But it was a pilot study. We just had a very basic framework. We just wanted to even see if we could do whole genome on patients. And we only sort of looked at oncology findings, and it was really kind of hodgepodge, very ad hoc. And as we started doing more patients over those 2 years, we've sequenced 100 patients at that point. And then that's when we began to realize the issues with returning these findings. And this is where we stepped and involved the hereditary cancer program and the cancer genomics lab for helping us with clinical validation. And that's where in 2014, we began to create a working group to look at these variants and really have a management group as well as REB input, as well as harmonization within HCP about consent and contact information, how to list these findings as secondary finding, and really that some of these ethical issues and the risks that can come with germline findings was really a risk. And so we decided quite early on to have it as patients couldn't opt out. Basically, the way you would opt out is that you wouldn't go on study, that it's really a risk as part of the study. Moving on to now 2020, as we're evolving, it's really now consideration of future pharmacogenomics, as well as reporting of the other ACGME variants. And then also coming up to, well, what is our duty to warn people? Again, how do we get that information to patients properly and their families? And then a lot of this has resulted from key changes over time. We've seen different research attitudes about research genomic data. So I think there's been more trust in research-based data over the last decade as well. And also from the research perspective, there's a lot of moral distress when studying genomic data sets. When we talk to our analysts, when they see some of these germline findings and they're like, well, this shouldn't be anonymized, like this is actually something where we might be able to help somebody. To know that there's a process in place where it can be delivered to patients has really helped with that researcher distress as well as there's an increasing ability to interpret and communicate complex data and results to patients. And Sophie will talk about that more from the HCP side. I think we're also seeing changing attitudes of patients and the general public towards genomic data. A lot of this is due to the commercialization of genomic technology. Now, some is for the better, and some is, has made things more complicated with the advent of a lot of the genomic technology out there. But I think it does tell us that the attitudes have shifted in terms of how do we, now that genomic technology is available and that patients are getting used to seeing some of this information, can we make sure that we're delivering it in a proper manner versus a commercialized manner? We've also been very fortunate to have the foresight of the REB to develop guidelines, and we've had access to really expert clinical ethicists, Alice Rani, Holly Longstaff, Nina Prado. They've all been heavily involved in terms of POG as well. Not only just on the ethics side of like germline findings, but Holly's been great in terms of the privacy issues as well. And it's really helped us establish this framework. So Alice has really been our key consultant with a lot of the clinical findings. And Caron, who's the REB chair, sits as part of our POG ethics and germline working group to make sure that there is oversight and that we're harmonized within the REB framework as well. And so as we're establishing the framework, it really was a collaboration with the clinician, the scientist, cancer genetics lab, HCP. And this is what I think was the most important thing that came out of POG was this collaboration. And this is where we created this ethics and germline working group in 2014, which was really to identify, review, and come up with a mechanism of returning these germline findings to avoid the moral research distress. As well as by involving the clinical sides, this allowed us to have the validation of the germline findings as per standard of care. And then we standardized the reporting and return of the results. And we made sure that HCP and the Cancer Genetics Lab are part of the overall POG management group as well. So it's not just this separate group, they're actually part of the overall arching framework of POG as well. So a lot of the lessons that we learned from the ethics is initially there was really lack of a clear process to return these research findings, and it really developed in a lot of moral distress for the researchers. Part of it was also shifting to treating germline findings as a risk. And I think we were a bit ahead of the curve. That was when it was, most research was developed as patients could opt out. But this led researchers into that moral distress in the sense that they would find a germline finding. And if the patient opted out, a lot of people would say, well, we know this person is sitting on a potential genetic time bomb. We really should do something. And it's very hard as a clinician then to go back to the patient and go, well, remember when you ticked that box that said you really didn't want to know, but what if I know, like, but now there may be something you might want to know. Are you sure you don't want to know that? Like it's just a huge quagmire of ethical dilemmas. So this is why we felt it was just really a risk. We harmonized our research consent with HCP so that this way it could include the next of kin contacts, so that this way it's a seamless consent process all the way through HCP, getting HCP and the CGL to aid with our clinical validation, and really having this oversight group to look over everything and report to the REB. Now, moving forward, we want to ensure the appropriate interpretation and communication results to both the oncologist and the patients. We are thinking about expanding our germline testing to include the pharmacogenomics and other actionable ACMG variants. So we are in contact now, working with the gastrointestinal group, as well as neurology and cardiology, so that perhaps since we're doing whole genome, maybe we could be better about expanding things and then referring patients on to non-oncology variants. So this has really been the next step. And it's, so we're doing well pre-COVID. COVID kind of threw things off the rails a bit. So we do have to get back in terms of this clinical follow-up with the non-cancer related germline findings. And the other big piece that we're trying to work on is our duty to warn. So really, how do we improve communication of these germline findings to patients and their relatives? And it's just like Claudia expressed, is how do I tell my family members this? Or there might be families where, I assume you get along with your brother or sister, but that may not be the case. And maybe you don't even talk to your siblings. And it's that fair as well. On the flip side, is it fair for us to be giving this information to people? Do they really want this information? So there's a lot of complexity still that we have to go through, especially with respect to privacy. So this is I'm the part where this is where we came from. I'm going to hand it over to Sophie, and she's going to talk about the HCP side and where we kind of threw this big bomb into her court and how she dealt with it. So, Sophie.
Thanks, Howie. Hey, can you move to the next slide? Thank you. So, I guess sort of sharing kind of personal stories. So Intan Schrader is a medical geneticist, and I'm a medical oncologist. We both work at BC Cancer. But what I actually just remembered when you were speaking, Howie, is that Intan and I came into this role as co-leads of the Hereditary Cancer Program, by meeting through POG. It was at a POG meeting. We just sat next to each other, and at that time we realized that there was going to be a vacancy, and we just sort of looked at each other, and then we crafted this plan. And we sort of joke a little bit about how, I'm tumor and she's normal, and it's always great to sort of have all these different brains. And I think one important piece, and again, just sort of going back in time a little bit, was really establishing a pathway, a clear sort of a clear way forward in terms of how to identify, report, communicate, germline findings that we were looking at, I guess, right, with POG. And so again, back to when we were establishing sort of the POG germline and ethics group, moving forward, we have sort of, I think, modified the approaches, but up to, the current state is that we are testing for a large number, 98 cancer susceptibility genes, and as Howie mentioned, we are talking about expanding this further. And in some instances, we do test for specific genes or variants requested by clinicians that may affect treatment or may be already known on the clinical side. And essentially, I think the results fall into one of three categories. One is we don't find anything, and in that instance, there's no further follow-up. And then in terms of what we review at our POG germline and ethics meetings relate to more these potential these known or expected pathogenic variants that can occur. And we also do review variants of uncertain significance. And I think what is an important piece in terms of the pathway is that those of us who are involved in the research study are also the clinicians who would handle the potential germline side of things on the HCP side of things. And so we do have a process, it was important to establish a clear process in place where and the same people who are on the POG ethics, POG germline committee are also the clinicians, the lab scientists who would be potentially clinically reviewing and reporting these variants. And really, I think what happens is that there's just a bit of a seamless handover, if you will, of the results through the HCP and the clinical lab overlap to then have these patients referred for clinical confirmation of the research findings. And that's, I think, just been key and integral to making sure that these findings don't fall between the cracks. And so on the HCP side of things, essentially we have a process in place where the research germline reports, genetic test result reports, will be sort of directed to the clinicians, and the clinicians are advised, asked to inform the patients, and in parallel, they're sort of sent emails with their HCP referral form, and we essentially sort of try to get that referral piece, underway as quickly as possible, because some of these patients are unwell, might need their DNA banked and so forth. Next slide, please, Howie. So the clinical confirmation piece is key. And I just had a few cases that I was chatting about with the team. And one was a pediatric patient who was actually identifying with a pathogenic germline BRCA2 variant through POG. And unfortunately, which can happen not infrequently, is that the patients die or, are prior to us being able to return the POG germline results. And this was a key piece that Howie mentioned, where we embedded in the consent form, paralleling sort of the HCP documentation. What we do in the HCP clinic, on the HCP clinic side, is to obtain next of kin information, so that if something happens to the person who's had testing, we want to be able to return that result clinically, and so sort of to the patient or their relatives. And so we reviewed the findings, realized the patient was deceased. The POG clinicians, pediatric oncologists were there, and they informed the next of kin, and ultimately the parents were referred to the HCP for clinical confirmation for the genetic counseling and had testing, and this was confirmed to be present in the family. Next, Howie. Just a second case relates to a patient who was identified with a pathogenic germline mutation. I don't have the details, sorry, but we can just, you can imagine it could be a BRCA or Lynch or something that would be potentially actionable through POG. And they were actually seen at the HCP for confirmatory clinical testing. And in this particular scenario, this patient was young and actually had his sperm banked before his cancer treatments. Unfortunately, he passed away, but afterwards, his spouse was in contact with the Hereditary Cancer Program. And because of the findings that were identified and confirmed clinically through POG and the HCP, his living spouse decided to undergo pre-implantation genetic testing of his banked sperm prior to undergoing IVF. So again, it's this idea that the importance of actually being able to identify potential germline findings on the research side and the relevance to patients and their family members. And I think in the past, there was this idea that we shouldn't look, and not necessarily. It almost seemed like we were opening up a Pandora's box by looking at germline, potential actionable germline variants on the research setting. But I think that we're kind of swinging the other way now, where it almost feels unethical to not look for these if we have the ability to be able to report out on these on the research side. And the most important piece is being able to rapidly clinically confirm them as well. Next slide, Howie. I think this slide is just more to highlight that the clinical impact of research findings, and it's not just for the patients in front of us, but also their relatives. And so research, reporting on these germline findings in a research setting can identify patients and relatives with hereditary cancer who may not meet traditional testing criteria, and we would not have otherwise known about these patients and the risks in their family members if we didn't look for them. And more so, the hereditary cancer genetic testing is being used to inform treatments for patients. So again, if we didn't look for them, and this may result in a patient not accessing a potential life-prolonging or life-saving type treatment. And there are also implications for family members who may be eligible for genetic testing, screening, and preventive measures. So at the HCP, we treat not just patients, but really families. And so if we don't look, then it represents a missed opportunity to be able to, again, identify these families who could be eligible for cancer prevention and screening. Similar to what Claudia was describing in terms of, this sort of the mixed feelings around, knowledge versus knowledge, but also, sometimes in some instances potentially causing, stress, but also the flip side of trying to find that silver lining where this knowledge can be actually very powerful and help families. And one other piece is that we at the program have been trying to redirect our resources to trying to improve carrier testing rates in families. We do know that, that the information can be difficult to communicate within families, as Claudia described, and it was my ears perked up when she was mentioning this potential avenue of perhaps, we as the clinicians taking on some aspect of that, of, we as at the HCP being the ones to contact, family members directly rather than burdening the relatives. And we've had different sort of conversations and we've created a bit of a duty to warn, duty to report committee that we, trying to look at potential ways to help improve that communication piece. And another aspect really relates to, what do we do after we identify people with, families and individuals who are at high risk, and are they able to get the adequate supports, not just sort of their screening and their prevention and their scans and so forth, but also the psychological supports that are needed. Next, Howie. Guess that was all. Yeah.
Thank you,
Lots
Jennifer.
to do.
Yeah, a lot to do. Thank you. You've set the stage up well for Jennifer.
I'll just get to sharing my slides. Hang on here. Okay. Yeah, thank you very much. Claudia, I wanted to say just really grateful for your moving and eloquent snapshot into the lived experience of someone with a hereditary cancer condition. I think that really focuses us on the patient piece of all of this ethical sort of theoretical talk. So thank you for that. And interesting to see, Howie and Sophie, what you pulled out to talk about today. You'll see some of the same reflected in what I'm going to share, but I think it all complements each other really well. So thank you for the opportunity to be here. I think it's tough to narrow down to 10 minutes what you want to say about the ethics of genomic research. I think we could have days talking about this, but here we go. So I would also like to respectfully acknowledge the unceded traditional territories that I am connecting with you from today, and those are the Lekwungen speaking people, also known as the Songhees, Esquimalt, and Beecher Bay First Nations communities. I think it's also important to spend just a brief moment on the lens that I see this topic through. We all have our own lens, our own implicit biases, our own experiences. I'm certainly first and foremost a clinical cancer genetic counselor. So I work, as mentioned, for the BC Cancer Hereditary Cancer Program. That's the HCP that's been referred to. And this is a clinical, publicly funded service to provide hereditary cancer genetic counseling and testing to the population of BC and the Yukon. We do engage in research, as has been demonstrated, both in the scale of something like the Personalized Onco-Genomics Project and smaller studies, but we are always bringing it back through that clinical lens, and that's where I'll present from for you today. So I wanted to provide a really quick snapshot. I think more and more people have heard about what is a genetic counselor. I think, we used to go to cocktail parties and say I work in healthcare, because you'd say you're a genetic counselor, and that would lead to a 20-minute conversation about what it is that we do. But I think it's also important to highlight that genetic counseling, which is truly and in its most simple, a process of helping people understand and adapt to genetic disease and all of the implications that that has. It doesn't have to be performed by a genetic counselor. So increasingly, there are other members of the healthcare profession that are providing aspects of genetic counseling to patients in the public. This process really integrates three key pieces. There's an interpretation part. Sorry, I'm having trouble with my mouse. That's looking at family history, medical histories, genetic test results, genomic test results, tumor test results. Increasingly in that complexity that Howie spoke to, there's lots to talk about and interpret. So there's a skill set here in tying it all together to hopefully communicate out to patients and their care providers, what's the chance of a disease coming back? What does all of this information mean for families? There's education components for patients, for the public, other healthcare providers on various aspects of hereditary disease. And the counseling really comes in around promoting informed choice and not just giving that lip service, but really trying to help people make decisions that fit with their life and their lens and their perspective, because they're the ones that are going to live with those choices lifelong. There's also a piece about helping people adapt to a risk that's been shared or a new condition in the family, which Claudia spoke to so well. So, not clinical counselors by any means, but there is, specific focus on the adaptation and choice piece of this for patients and their families. So this looks really busy and crazy on the screen all of a sudden, but I think it's really important to talk about the fact that with increasing tools and technology, it's becoming a lot easier, a lot cheaper to find variation in the genome, and it's quite normal to have variation. So if we're looking through the DNA code and we see a spelling change, we can pick those up fairly well now. But what does that change mean? Is that something that's just normal variation that's common and expected? Or is that potentially related to disease? Does that letter change make a gene stop working, and then we have something to be concerned about? And just a nod maybe to our next speaker is that a lot of the reference data that we have to determine is something normal or pathogenic comes from very specific populations in the world. And so there's a real need to expand that to make sure that all populations can benefit from genomic research and genomic medicine. So the first point I wanted to make is that there is a difference between variant identification and variant interpretation. So we can find the variation, that's great, but what does that really mean? And I think that's what patients are looking for, is what does that mean for me? So if I'm thinking about research ethics board folks who may be here and looking at applications, who's going to be interpreting the results of the research that might be happening? Where are those results generated from? So not all tests are created equal. How much can we rely on the quality of the data that's being presented? Are the results generated, or as you've heard previously, are they confirmed in a clinically accredited lab? That's really important. And if we think about this idea of, is something benign and normal or disease causing, that's all about variant classification. So there's a whole rubric to classify variants into, are they disease causing or not? And we're grateful we have molecular geneticists and bioinformatics folks to do that for us. But it's not easy, it's not straightforward, and it's not static. So this evidence base for what a variant means is constantly evolving. And one of the things that I've heard from researchers is some challenges in terms of, well, what if we get new information about the results that we previously gave to a patient through a study? Whose responsibility is it to recontact that patient? Do participants know upfront when that may happen or how this may happen? Are there resources available to recontact patients and share this information, which may be really quite critical? Beyond interpreting the initial variants that are found, this has also been mentioned, is the point of communicating that information out to participants, patients, families, healthcare providers. So some examples that come up here and common misconceptions is that if we don't find anything on genomic sequencing, that means nothing's there, everything's okay. And that's not true. We could have missed something based on the technology that was used. Or that a negative result might mean that there's no risk or the disease won't happen. That could be a common misconception. Another piece that's important is that the penetrance of the disease that's been of the variant that's been found, which just means what's the chance that the disease is going to come, may be really context dependent. So you might see there's a pathogenic variant in one patient, the same variant comes up in another patient, but they may mean different things depending on other genetic and environmental factors. So there's some interpretation pieces there. The other one that, I think lots of people have heard about now is sometimes we find a variant and we don't know what it means. It could be benign, could be disease causing, and they call that a variant of uncertain significance, which is a mouthful. So we call it a VUS. And these are often, unfortunately, misinterpreted and sometimes given more significance than they should be. And people may make life-altering decisions on that kind of information if it's not clearly communicated that, yes, we found something, but we don't know what it means. Don't act on it. So that all kind of rolls into communication and how do we do that with people. And there's a real value here in plain language. And I put up this quote from some work that Devin Poznansky, who's in patient education at BC Cancer, put together, a workshop that she does, to say that plain language is really achieved when somebody can easily find the information that they need within whatever form of communication you're giving them. If it's written, let's say, they understand what they find and they can use that information in their decision making. So that's the goal of plain language. And why that's important is that we know that there overall in society is a relatively low level of health literacy. So these are some stats again from Devin that were, a little bit surprising to me when I first heard them, but it makes sense that over half of Canadians aged 16 to 65 have low health literacy, and that increases to the great majority over the age of 65. There will be members of vulnerable populations who will have low health literacy, so those who might be of a lower socioeconomic or education status, some people who have English as a second language. I would also say that any one of us can experience low health literacy at any time. So I appreciated, Claudia, your experience of you have a tumor and then that's it. Obviously an educated person who is in a very stressful context and scenario, and we can't assume that people can just understand everything that's being given to them. So how this can impact healthcare is that, we can't really change people's health literacy levels in the moment when we're sitting with a patient or a research participant. We can't change the scenario in terms of the stress level sometimes, but we can try to make it easier for people to get the information, to understand it, and to use it. And the whole reason to do this is that hopefully people can more fully participate in decisions around care and treatment, or relevant to the talk today, perhaps around their decisions to participate in research and to understand the results of that research at the end of the day. So I don't like to have sort of genomic exceptionalism. I think that, genomic medicine is just medicine. It's one other tool in the toolkit. But I think we can appreciate, as Howie mentioned, that there is growing complexity with genomic sequencing. And so how do we explain that complexity to people who aren't schooled up in the field of genomics? We can't always explain, as I mentioned, the significance of genomic results. We can't predict everything we might possibly find, especially when you're looking on the scale of the genome versus, let's say, a few single genes. And the clear risks and benefits of genomic sequencing are fully known yet. So in terms of making an informed decision, the standard sort of historical aspects of consent may not be available to help people consent to genomic sequencing. My last piece about this is from a meeting a couple of years ago at the American Society of Human Genetics, and Barb Biesecker, who is sort of one of the founders of genetic counseling, let's say, was that, even in our field where we're trained to communicate, hopefully in a straightforward manner to patients, that's the whole part of our job. A lot of studies have found that we're so eager to tell people all about this wonderful world of genetics and all the things that they possibly would want to know, that it's just too much. There's too much information. The health literacy level is often too high. We're talking about probabilities and risk estimates, and that's just not something that everyone can take in, understand, and use, especially in a short session. So her recommendation had been that genetic counselors should really focus on the consequences of genetics rather than the scientific concepts. And again, it's, what does this mean for my family? Why did my cancer come? Am I going to get another cancer? Is my kid going to get cancer? and less so about some of the context for why we're doing the test, how it's going to be done, those pieces. So I think I've seen, and maybe lots of us have seen, some genomics research consent forms that are 12 pages long, and there's lots of detail in there about what the study is going to do and the possible results. But I think we can probably do better in thinking about plain language, thinking about what are the key pieces that people need to know to make an informed decision to participate in this study. And that could then play out into the conversations we have afterwards if we're returning results. The other piece that I think would be great to see is how do we assess patient understanding? So, we develop these forms. It would be great to have some patient partners involved in developing those forms. And at the end of the day, how do we know that people really understood what they're consenting to, what they've been through, and what they're taking away from the study? So last piece, I'm not going to be quite under my 10 minutes, Caron, apologies. So the last piece I wanted to touch on was privacy. And this has been a really sort of hot topic for us for some time, and really in that space that's been alluded to already about people's right to know, and thinking about genomics as not necessarily an individual disease, but potentially a disease of the family. So when we think about the rights of a proband, which just means the first person in a family to have genetic testing, we can think about things like privacy, confidentiality, autonomy, but we can also think about those in terms of the rights of the relative, and potentially also add in right to know or right not to know. So some people don't want to know this information, and that's certainly their right as well. We've had lots of conversations around for the proband or the patient, is there a moral obligation to tell family members? And as mentioned, for those of us ordering the testing, is there an ethical duty to inform relatives? So this all gets a little bit theoretical, but what I mostly wanted to say, which I think is interesting from this study here, my Zoom bar is in the way, is we can think about information maybe in a couple of different ways. So if we think about someone's cancer diagnosis, that's personal clinical information, and that's potentially confidential to the individual. But when we think about there we go. Genetic information like a BRCA1 pathogenic variant, which is a gene related to hereditary breast, ovarian, prostate, pancreatic cancer. Maybe that's more confidential to a family, and we don't have to apply that same idea of individual confidentiality. And there has been some support internationally for clinicians, potentially researchers, who are aware of at-risk relatives to offer genetic testing without documenting consent from a proband. And so it gets around that idea of, Claudia, that you mentioned around, well, what if I don't want to share, that kind of idea. It does give permission in a sense for clinics to actually reach out to relatives, as long as we don't reveal, who we first found that mutation in, let's say. And if we make this explicit to patients during their pre-test consent discussion, this is an example from their consent form, then people know that this implication may have, or this testing may have implications for me, but it may also have implications for my family. And this clinic is going to, use that to inform the healthcare of my family members if that comes up and if it's appropriate. So this idea of a familial approach is also grounded in something called relational autonomy, where we see an interdependence between people, and in this case, in a family, versus just a sole independence of a person. And here we're thinking of principles of beneficence, so to do a good thing for family members, fairness, because just because one person happened to come forward first in the family and have this genetic test, should they sort of now have veto power over who else gets to know it in the family? And also reciprocity. This is more the clinical space, but maybe someone needed to share family history information in order to get publicly funded testing, and so the reciprocity piece would come in sharing genetic test results. I won't go through these values here for sake of time. I think they're fairly self-explanatory, but just wanted to wrap up by saying that the respect for individual privacy, without thinking about the broader social and cultural context that shapes preferences within families, it probably truly can't be the foundation of policy and sort of the thing that takes precedent over all other considerations. So I think what we're looking at is a shift, at least in the clinical genetics world, towards this more familial or relational approach, seeing individuals as socially embedded in a network of others, which is true for most, and providing an opportunity to critically reflect together with patients or research participants about their result and what that means for them and their families. The last thing I'm going to say is that I think it's really important to have patient, participant, societal perspectives in all of this. And when you look at the literature of studies who have actually gone out and sought some of those perspectives, for the most part, people want genomic findings disclosed, whether that's from the clinic or from research studies. So I know there's lots of talk around, do we disclose genomic findings? But to Howie and Sophie's point, there's lots of distress if we can't do that. And I think most people want those to be disclosed, especially when the information pertains to a life-threatening disease, something that has high penetrance, which means that it's highly likely to come, and especially if there are effective ways to prevent the disease. So that's the whole reason that a lot of people in our program get up every day, is to think about the potential to truly prevent cancer through genomic medicine. In terms of family members, again, most people involved in these studies have few concerns about sharing genetic information, and their concerns are more about the health consequences of not sharing. I think to your point, Claudia, people want this to happen, and they also feel a burden of having to do it themselves. So if there's a way for a clinic like ours to step in and say, give me your cousin's phone number, address, however, we'll reach out, that may help remove some of the burden for patients and families, and make sure that the information is communicated in a way that is understood by the person we'd like to see next. So there's lots of further reading out there on all of these topics if people are nerdy about it like me. And I'm always happy to take questions now or after the talk today.
Thank you, Jennifer. I think we'll take questions after. So the last speaker is Nadine Caron, who has given a lot of talks around different perspectives, and I look forward to hearing her talk, and then we'll take questions. Thanks, everyone.
Thank you so much. An honor to be on this panel. I have learned so much, and my brain is just going with questions myself. I'd like to acknowledge that I am joining you today from the traditional, ancestral, and unceded territory of the Lheidli T'enneh, which is also known as Prince George up in northern British Columbia. And I got this email saying, can you send the slides for your presentation, by this time? And then I thought, oh my goodness, people are using slides, so I got to get slides together, which means you have to have a title. So I had to come up with a title, and it had to be something kind of catchy, because I knew I was going to be last and everyone's going to be kind of getting a little bit tired. So stick with me here. So I thought, first of all, well, you know what? I'm going to be with really smart people on the panel. They're going to have a ton of experience, and they're really in the trenches here with their work and what they do. So I thought, what about perspectives of an Indigenous researcher? Because I'm a member of the Sagamok Anishinaabe First Nation. We all have our perspectives, and they can't really be wrong. There might be opinions you don't agree with. They might be something different, but I thought I'll be safe perspectives. And then I thought I'd use the slogan, "Nothing for us without us," as a perspective of an Indigenous researcher and an Indigenous person in Canada. A slogan and a phrase that the First Nations Health Authority often uses with any research or any programming, pretty much anything in the healthcare system. So if you're going to work with us, do it with us. And then I thought, okay, let's see here. What about this, though? There's all this stuff, especially now, about diversity, equity, and inclusion, and there's all this pressure. And these are things that if you don't have these in your mandate, if you're not talking about them in the boardrooms, you're really in trouble. So I thought, what about this? And then when will we really commit to this in the spectrum of research? And are we talking about diversity, equity, inclusion in terms of the participants of research? Are we talking about way upstream? What about the board in the boardrooms of the funding agencies who are deciding like what's going to be funded? What are going to be the RFPs that are put out? How are we going to decide what is excellent research? What's a great question? What's a great project? What about REBs? So the diversity, equity, inclusion, do you have the perspectives you need to really be able to address all of these questions that are coming out from the patients, from the families, from Indigenous peoples? What about researchers? Is Indigenous research with Indigenous people, or is it research by Indigenous people? Doesn't matter. And so these are some of the questions that I was coming up with. And then I thought, okay, genomic research with Indigenous peoples in an unethical country. So we got to kind of take a look back. This just take the pressure off the REB members out there in the audience, because quite honestly, when you're in the scope of what we're going through as a country in Canada right now, you have a small little role. And so when you're really feeling pressured, be relieved that there's massive problems out there that I think we have to deal with much more on a broader scale as a country. But it's important to remember, because when you look at everything from how we approach patients or how we approach participants or families or communities, consent forms, and what makes sense and what doesn't make sense. Think about recently the National Truth and Reconciliation Day and what hopefully the people in the audience were thinking about in terms of what is reconciliation and what are we trying to reconcile from. All of a sudden, I think that we might see things through a different lens, to use Jennifer's idea there. I love that idea because it is really, really important. And I was thinking, how do I explain this? Well, it's sort of like if you've ever been next to someone who gets a little bit antsy with turbulence on a plane, would you think differently or treat them differently or reach out your hand to help them differently if you had known that the year before they had survived the plane crash? I think sort of taking a look at our country's history that we're doing the research in is actually not a far stretch from what we need to do. And then I thought, okay, but let's start off with genomic research with Indigenous peoples guided by voices previously silent. Because I think now we're really getting into the space where Indigenous voices are actually being heard. They're being heard in various areas in our society, whether it's education, justice, environment, healthcare, and health research. And I think I'm really honored to be on this panel today because I was asked specifically, can you share some thoughts about Indigenous research? And I can say that 5 years ago, especially 10 years ago, that wouldn't have been on the agenda. I would have been maybe to ask, in terms of what's your experience in the North, what's your experience in the distributed medical program, but I don't think Indigenous research would have been on the agenda. And so my thanks, Chi-Miigwech, to the organizing committee who put this out there. And so now I've used up all my whole time almost, and I've talked about my titles, but I'm going to zip through these. I put it as a question, but I think it's actually the answer. Can access to research be a determinant of health? And I think it can be, because I think we're all here for a research symposium. And if research does what it's supposed to do, you have a question, you don't know the answer, you collect the data, you analyze the data, you come up with a solution, you get partial answers, you get the next question, you maybe change policy, you develop a program, you analyze things so you can make it better. Whatever it is, research is supposed to do good, or else it wouldn't get through the REBs. Benefit versus risk, REB would have stopped it to begin with. So research does have a benefit. Therefore, if you don't have access to it, you're less likely to benefit. If you get access to it, you're more likely to benefit from it. And I think the World Health Organization said it even better when they talked about the genomic health divide. And they just basically said this needs to be kept in check and ultimately bridged through equitable economic investment, clinical research, provision and use of genomic services and technologies globally, because there is inequities in this. It costs money, it takes resources, it takes incredible bandwidth. And so where there's inequities globally, there's inequities in this microcosm of Canada, especially when you look at North versus South, Indigenous versus the rest of Canada, rural versus urban, and the list goes on. So silent genomes, I'm going to spend a couple minutes on a couple projects that I have the incredible honor to be part of. Silent genomes, the lead is Dr. Laura Arbor, who's a medical geneticist who spent like 30 years as a medical geneticist working with Indigenous populations in the far north. And our project is to reduce health disparities and improve diagnostic success for children with genetic diseases from Indigenous populations in Canada. I did not plant Jennifer in the panel. But thank you, Jennifer, for putting that out there. Because let's see, we have this thing called this, the NOMAD, which medical geneticists use to help to make this diagnosis for individuals that are being referred for potential genetic etiology for this. NOMAD is made up of about 130,000 genome sequences. And you can see here that it's broken down, and a bulk of it is European in terms of the background. And of course, there's some Latino, there's some South Asian, some East Asian, and then there's this darn thing called the asterisk. gosh, it is so frustrating to be part of the asterisks. And Indigenous people are often part of the asterisks. If you just pick up any article on anything in any medical journal, for the most part, Native American data not available. You know, Native American not concluded. That's for the Americans. For Canada, it's like First Nations data not included, Indigenous data not available. But in this case, looking at a clinical tool for clinical diagnosis to potentially aid in treatment and services, you can see here that this is where Indigenous people may be, but we don't know. We don't know because there is no Indigenous identifier in the NOMAD. And so if you're European and you walk through the door of Dr. Laura Arbor's office, she will be able to use NOMAD and have this incredible tool. If you're Indigenous and you walk through her door, she will go through the same process and she will try her best. But according to Laura, she is absolutely tethered by the inequities in the ability to use tools that are specific to Indigenous peoples. Because when you look at all these things like the 98 cancer susceptible genes, is there any of those that are specific to Indigenous peoples? Knowing that we have a way higher rate of colon cancer, we have higher rates of gastric cancer, we are dying more from cervical cancer. Like all of this, the question is, I think we need more space, we need more access to the research. So silent genomes is basically 4 activities. Activity 2 is access to increasing access to clinical medical genetics and genetic counseling. Activity 3 is building an Indigenous background variant library. Cutting to the chase, it's creating an Indigenous nomad. So that next time Laura, if she has this and someone walks through Dr. Arbor's doors, she'll have an Indigenous nomad for an Indigenous patient. Activity 4, Dean Regier leads this up. It's the economics of this whole space. And then you'll see that activity 1 is a huge square or rectangle. Not because I made a mistake or that I'm not that good with PowerPoint, but because it is significant. This activity is the JAWS component, massive JAWS component. Knowing activities 4 is economics, but it's engagement, governance, capacity building, collaboration, partnership building. It's all of that that is necessary for activity 2, 3, or 4 to even be possible. And I'd love to talk more about it, but again, we all had lots to talk about and we run out of time. Northern Biobank Initiative is the second one I'd like to talk about briefly. So essentially, as an Indigenous community member, just in Canada, but as a physician and researcher, I witnessed from my early years to now this evolution of genomics and how it became paramount, even in surgical oncology. So first of all, there's media coverage of medical study findings and direct-to-consumer tests like 23andMe. And then there was conference sessions where all of a sudden I would be at a surgical conference and they'd ask me talking about genomics, which surprised me. Patients started asking questions and they had expectations. And then all of a sudden I was going to these conferences and I was starting to get to know these people like at Genome Sciences Center, people like Mark O'Mara and Ali Carson and all of a sudden kind of going, wow, they're doing this research and it's getting to the bedside. It's actually impacting cancer care. It's phenomenal. But I was wondering when I was sort of taking a look at this, one question that had never been posed, despite all of this evolution and this growing role, was what bedsides were getting to the bench. And it was a question that couldn't be asked or answered. And so started going through a process. And similar to POG, actually around the same time, 2011, we started talking about how do we get to be part of this process. In 2012, we had a workshop in Prince George with First Nation community members to say, this is a biobank, what do you think? In 2014, we had focus groups with primary care providers across the north and asked them, what would your patients think? What would you think? And had incredible feedback. So for a couple of years, we tried looking for funding to see who would fund a biobank with no research question. It was a research platform. And so we finally realized that there was going to be no funding from CIHR or any of those for just a biobank with no question. But with the help of Northern Health, First Nations Health Authority, BC Cancer Foundation, PHSA, and Genome BC, all of a sudden together they funded this initiative, the Northern Biobank. And so 2016, it was launched with a national meeting about DNA on loan on how to protect DNA and biospecimens in the context of Indigenous people's expectations, and it's still going on. Lots of people were a part of this that are maybe in the audience. Peter Watson was incredibly supportive. Sheila O'Donoghue from CedarNet and Ober was huge. Holly Longstaff, Alice Ranney, Michael Burgess were on speed dial. It was incredibly helpful. 54 First Nations in Northern British Columbia, 54. And their voices all needed to somehow be part of this, a process of engagements and consultations that took 2 years before we even started to do the actual formal consultations. The question that we brought as a team to First Nations chiefs and health directors and the executive of the FNHA is, can we discuss the potential of a First Nations biobank with your communities? And after 2 years, when we were getting pressure, like, why is it taking you so long? Why is it taking you so long? We got the word from the chiefs to say, you know what, you can go and talk to our communities. This is a community level consent. You can go talk to our communities. But we don't want you to ask you, we don't want you to ask them, should we have a First Nations biobank? We have gone through our proper channels. We have gone through and talked to our community members if they want it. So ask them, how should we create a First Nations biobank? And all of a sudden, we slowed down to do this engagement, and it actually sped things up in a culturally safe and relevant way. So I'll finish with just a great quote that I love. Being an Indian is not about being part something. It's about being part of something. This is on the wall of the Smithsonian's Native American History Museum by Angela Gonzalez, who's a Hopi scholar. It's complicated. It takes time. Sometimes Indigenous people may be seen as inconvenient. We're not located in metropolitan Vancouver or metropolitan Toronto or Montreal. We're often, the more north, the more rural, the more isolated you get, the higher the percentage of Indigenous peoples in Canada. But don't take any of that to make it seem like we don't want to be there. We want to be part of these conversations. We want to be at the table. We're excited about this. And by that, I'm not saying that everyone wants to be part of it, everyone wants to be in a biobank, or everyone agrees with this. But what we are asking for, and I'm just guessing this because I can't be a representative of Indigenous people, but I can say from what I've heard, more pronounced than anything I've ever learned in my entire career, is that we want a choice. We want to be able to say, yes, we want a biobank, or no, we don't. Yes, we want to be part of that research project, or no, we don't. Yes, we believe in the vaccines, or no, we don't. Yes, we want to be part of that genomic study, or no, we don't. Please, let's work together so that choice becomes something that we can all expect as Canadians. Thank you. Chimigwech.
Thank you, Nadine. That was an amazing presentation, and you can see from a lot of the chat line that others are certainly having the same response that I've just had. So with that, I'd like to throw open the comments and the questions. And before we go into some of the questions, there's a question that Howie started to answer that I think is important. And Howie, I'd like you to answer the question that you started to do in the chat line around, can we use public health types of models and frameworks to, in terms of notifying, to inform how we do information about genomics? And I think you start to answer this, but I think it's important we talk about this.
Yeah, so I think this is where we started this small subgroup, duty to warn subgroup. So I think Jen's been on it. We had Holly and Sophie and yourself. And we looked at various models. There is the model in Denmark where the system does, through the GP, try to notify potential affected carriers. And there was survey results about that model. We wanted to see how the CDC does it, because arguably you can say that genomic information is somewhat communicable, being passed on to the family. So I think this is where we are still struggling with what is the best model, what is the best approach. I think when COVID hit, it kind of helped, it deflated some of our steam right now. So I think we just have to get back on the horse to get things going. I don't know, Sophie. And then a lot of it's also now technology. Can we utilize technology to inform people? And I think, Sophie, you guys have a portal that you're working on as well.
Yeah, I think I feel very, I don't know, I'm opinionated about this one. It's just this idea of there's can be this circumstance where at the program we sort of see family members, and there are instances where for various reasons, the person who, let's say, is tested positive does not want to share that information to family members, and then fast forward, in parallel a relative is now being seen at the HCP with a potential preventable cancer, and they are, eligible for testing. And there's just a lot of tippy-toeing around not being able to share this information when it clearly can affect the way we manage patients, and can affect sort of, patients' decision-making around their own treatments, and even prevent cancers in their family, in their relatives. And so that's sort of where this sparked this duty to warn committee. And we were connecting with these I have a good friend and colleague who works in the HIV world. And it was this idea of, how do we sort of piggyback on that sort of model? And this was again pre-COVID, but even thinking about the different tools that are sort of being used with contact tracing with COVID, like how can we sort of build, I guess, break down those barriers that seem to be there around hereditary cancer, testing results and that sort of thing, because
So there's a question that actually feeds into this that Jennifer might want to take, and also then Claudia might want to take, and then there's a question for Nadine. But one of the questions that came up about half an hour ago was, how has the reception been from next of kin about receiving results positive, and how does BC Cancer's approach compare to cancer centers across Canada? So maybe Jen, if you want to talk about that, and then get Claudia's perspective on that.
Mm-hmm. Yeah, great questions. One piece of research actually we're doing right now through the BC Cancer Research Challenge is a qualitative study talking to patients and their family members about sharing and receiving genetic test results, how it was received, how did that work for you? Can you imagine receiving that information instead, perhaps, or as well as from the hereditary cancer program? So we do hope to glean some patient feedback in the context of a qualitative study to look at that. Our approach here in BC is very similar to that across the country, where it's basically, here's your positive results. We'll give you a family letter to share with your relatives. Here's the information for a clinic near them, but really it's up to the patient to share that information. I think what's interesting from the studies so far of places that are doing direct contact, which is what we've labeled it when the clinic calls out, is that most people are okay with sharing. And they may want to have an initial conversation with their family member because they know them, but then they really appreciate having that supported by the clinic to say, so-and-so is going to give you a call and talk to you more about this. And those clinics have seen a real uptake in carrier genetic testing, which is this family member testing after putting in place a direct contact approach. So hoping I'm answering the question there, but I think it is really a minority of people where they don't want to give consent, and we'd have to think about these broader like public health pieces where we don't have consent to share.
Yeah, and I guess a family's response is going to tell us a lot about what you and Sophie both brought up before about the family dynamics to start with. I mean, we're not going to change that necessarily. Claudia, what's your perspective, and what do you have to add to that whole question?
My mom got tested right away. My sister was advised to not get tested right away because she was in the process of buying a home, and we weren't sure insurance-wise if she would be approved if she had the Lynch syndrome. She eventually got tested. My family in England, some of them actually chose not to get tested, and I did have to stay on top of my cousin for him to get tested, just because we didn't really know where the Lynch syndrome came from. We couldn't test my dad because he was not here. I would really appreciate, and I would love to help out, just like for the patient not to be responsible for passing that information on, because it was like there were so many questions that I couldn't personally answer, and I was like I said in my speech, like I was scared.
Yeah, and I think, sorry to just add in, I think most, in my experience, and we have an ascertainment bias because it's the people that we talk to, but most people are grateful to have the choice, like you spoke to, Nadine, that the choice to decide whether or not to come forward for the testing, to have the information, whether they follow up with it or not is their choice, but they can't do anything about it if they don't know. And some people really have just had extreme gratitude for being able to be given the opportunity to prevent cancer in their family. So I'm sure there's challenging families. We know those where it isn't that straightforward, and people may get angry and upset and all those things, but we can work with that, and we can't work with secrecy. So that's my
I think the other thing is around timing. I mean, for a lot of patients, they get this knowledge, and I'm sure, Claudia, you can speak to this. You feel like you have to share it right away, and yet you don't. It's your knowledge to share, and obviously you feel like you might want to share it, but it's not something that has to be done as you drive away from the appointment or something like that. And so I think that's probably something that we have to also stress to people around the autonomy of having this knowledge, that it doesn't have to be right away, that it needs to settle, that you need to have some comfort with it, that you need to get the information and have the genetic counselor or somebody else help you share that knowledge. I'm going to change tacks a little bit. We'll come back to this around variants, but there's a question for Nadine around, is there interest activity to collaborate to expand the Indigenous Biobank across Canada or North America? So maybe you could speak to that.
Sure. I mean, that's a great question. For a small project, relatively speaking, up in a small community hospital, the Northern Biobank Initiative has gotten incredible support and curiosity and followers to sort of see how this moves forward. And what's important to note is that this is a project of the communities. Whether the First Nation, we're at the point now where we've done formal consultations with focus groups, with community members, with our advisory, with the and with the chiefs, and we now have an established sort of governance model that we're, similar to what you've heard already. COVID came, and there are priorities in the communities that it's like all of a sudden research sips way down to the bottom when you're talking about COVID, forest fires, and the like. So we're looking forward to reinvigorating it and establishing the governance. And so I think there's two issues. One is lots of people are looking forward to see how the North does this and learn, and what they've learned from it in terms of what the First Nations perspectives are and how that works, and recognizing that Indigenous peoples in Canada we're not all the same, and even in the North there's such heterogeneity. And so it's amazing how, despite the heterogeneity in the North, how there's a lot of common ground in terms of their perspectives and what they're hoping and what we've achieved in terms of understanding. But it may be very different even in southern British Columbia, and certainly looking across the country, or with the Inuit or Métis. And then there's also movements in terms of ideas in the United States, and biobanking. We've gone to our Northern Biobank team has gone to New Zealand to work with the Maori, because they are also looking at biobanking for Maori, which is, New Zealand is, geographically quite similar to Northern BC. So there's a lot of support for it. There's a lot of curiosity. A lot of people are waiting to see, how does this Northern First Nations biobank come to be, and then deciding, then the First Nations in the North can share their experiences. There have been lots of requests about partnering with the Northern Biobank, and particularly the First Nations component of it, but also just the Northern Biobank as a whole, because equity, diversity, inclusion in the area of genomics is not just isolated to challenges with Indigenous peoples, it's Northern populations, rural, isolated, remote. And so the NBI has been also approached for being participants in various projects, and we're looking forward to those types of collaborations, because I think What that does is it validates that researchers in metropolitan academic southern centers do see the value and the importance and the relevance of including all Canadians. And so the NBI as a whole is considering collaborations with other research projects. And then the other part of it is the First Nations. I can't speak to that because while I'm the PI, I can't stress enough that this is the Northern First Nations biobank, meaning that they will have to answer those questions for themselves. But I'm really excited to once again to be able to be the person who can maybe hook the Northern First Nations up with these type of requests so that they're given the choice.
So that's interesting because one of the things, we talk about all the negatives that have come out of COVID, but one of the things that I think is a positive that's come out of COVID is we're much more aware of using technology like Zoom for this session, and using Zoom, using electronic consent, using telemedicine, using all of these things. And certainly it's going to open up avenues for doing remote research in a way. Obviously somebody needs access to a Zoom, but certainly a lot of the hospitals around or communities have access to that. So and certainly through the Hereditary Cancer Program, we've seen a lot of projects coming forward using electronic health, using these kinds of resources. So I think your inspiration to say, let's get out there, I think putting those two features together could really change things, and that would be helpful. One of the things that came up, one of the words Howie used early on was around trust. And I think that that has come up a lot. A lot of genomics research has been coming from a lot of, barriers to genomic researchers has often come from a very paternalistic feeling that, we're the researchers, we have control of this. Oh, the poor patient, we won't burden them with this or something, and obviously Claudia has talked about the burden of telling families, but she also clearly said knowledge is power. So, we can't have this paternalistic feeling. So one of the things is around trust, and how, I wouldn't mind you expanding a bit on that in terms of where you see that coming, particularly in the framework of seeing the polarization around trust with the COVID situation. Do you think that's going to spill over into genomics at all?
Yeah, I think it's what you hit the nail on the head about the paternalism very early in research. And I think part of that might be to protect ourselves. We were like, well, we won't either look at that or someone doesn't have to know that, or we'll hide behind the blanket of, we'll just make it anonymous and stick it in the big bucket. Because this way we don't have to deal with it, right? Because once you open up Pandora's box, as Claudia's expressed, like there's a lot of effort and work that has to go into it. So, it's easy to say we shouldn't trust research data and et cetera. I think the honest truth is information is power, as Claudia has expressed, but it also has to be put in the proper context, and proper information is also powerful as well. And even explaining where we don't know things like the VUSs or variants of unknown significance, where we run into these problems. And sometimes we do return these variants of unknown significance because we say, we've reviewed the family history and like, well, you have this large family history, there is this variant, maybe this should be looked at to give people. So I do think as proper information is put out, you can engender trust by developing those relationships. And I think then this goes to Nadine's point about, I think with Indigenous communities, as long as we're making sure we're providing the proper information, then we can engender trust to make sure we're doing the right research in the right ways. Because I can see to a certain extent, if you put out misinformation or abuse the information, that trust can be lost. And we've already had a lot of trust issues. So I think it, I guess, spans multiple things. I hope kind of rambled there, sorry, but I hope that made sense.
No, it did. Does anybody else want to pipe in there? If not, there's a good question about, oh, sorry, Nadine. Go ahead.
I was just going on what Howie was saying is, it's trust, and it's also creating a space where different perspectives can be brought up, and it might not even be different perspectives, but the sort of the end of the spectrum. And so, for example, when it came to silent genomes and the process of writing the grant and working with the funders, that's one of the LSARC grants through Genome Canada, UNBC, CIHR, and multiple other partners. It was fascinating that once the grant was awarded, the paperwork to sign off open data. So like access to the data. When our entire activity one was to develop governance for the data, which meant that at the end of silent genomes, we would ideally come up with standards and guidelines and governance structures that Indigenous peoples participating in this and taking their time and their expertise and their efforts and their stories and sharing that so we could come up with suggestions for governance. But being asked at the beginning of the project to sign off, because that's the way Western methodologies are with genomic data now, like just you sign off access that it's going to be open access data at the end of all of it. And then the learning experience it was to how do you explain that it might be open access? We don't know. We're not saying it won't be, but we're saying that that's the whole purpose of the project is, who owns the data, who stewards it, what's the difference, who has access to it, who gets to define what access is. And it's interesting, I have a whole slide deck that I had to cut off because I wanted to be in 10 minutes, but the United Nations Declaration on the Rights of Indigenous Peoples was this thing that people hadn't heard about. And then it was defined down to UNDRIP. But if you go down into UNDRIP, it actually does say specifically that Indigenous people should have the right to even their own genomic data. Mm-hmm. It actually is embedded within that. And that used to be not so much of a deal when Canada said no, one of the 4 countries that just said, forget it, we don't want to be part of it, even though the rest of the United Nations, for the bulk of them, endorsed it. And then Canada said, okay, we won't defy it in 2010. And then in 2016, they finally endorsed it. But then now our own province, British Columbia, has the Declaration on the Rights of Indigenous Peoples Act. It is legislated in our province. And so now I think it's not something that's sort of obscure that Indigenous people bring up in board meetings to kind of get a point across. It's actually something that we really need to actually embed within the discussions and the policies as we move forward. And it's a fascinating space to be in, but more and more entities like Indigenous data sovereignty, which we've been talking about for years, are starting to roll off the tongue of places like ethics boards as they start to see that major data collection, this needs to be addressed and respected in order to move forward in spaces. And there's no other research that creates data the way that genomic research does.
That's a great segue into something that Claudia was talking about, her sister applying for a mortgage and not necessarily wanting to get, just again around rights and legalese things. Sophie, do you want to address what the law says now about the right to know genomic research in terms of employment and insurance, just for the audience? Because I think that's important, because I think what Claudia brought up is a worry that, somebody with cancer already has some of these issues, but when you don't have cancer, when you're an unaffected person, these issues come up. Do you want to address some of those?
Yeah, this comes up when I'm, when let's say I'm talking to a patient and they're asking, we're doing sort of oncology initiated genetic testing. They may ask a little bit about their relatives and implications for the relatives and so forth. And it's a line in the handout, but essentially there was a bill put in place, S201, that essentially the way I explain it to patients is that, by law, it's a bill where employers or external, insurance companies and so forth are not, and Jen, you may be able to describe it better than me, but basically are not, quote unquote, allowed to ask you as to whether or not you've had genetic testing or regarding genetic test results. So it was a bill that was put in place.
Yeah, it was put in place about 4 years ago by the government, federal government.
Yeah.
And it is, I think, a really important law. I mean, I think one of the things we all say is it's a law there now. We could get a Trump in power or something who would get rid of the law. But right now, we have that law in place. And I think it's something really important. And I'm sure, Jen, you can speak to it, that you deal with this all the time. But I think it is an important thing. And I think what Nadine is saying about rights, it being, I think we have to look at all of the different places where people's rights are being considered in the genomic space. So Jen, I don't know if you want to talk to that. And I also wouldn't mind you answering a question around that came from on the chat line of how often do variants of unknown significance get reviewed against current literature for a patient, as the status might change over time. And I think that's a really important question too.
Yes, those are good questions. So yeah, just to summarize about employment and insurance discrimination. So that's federal employment, I should clarify. So the Genetic Non-Discrimination Act was passed into law in 2017. Yeah, so it's right about 4 years ago in Canada. And it does make it illegal for those companies to request results of your genetic testing. I think we always have a bit of a caution about that, to your point, Caron, that, this is a law in place for now, and the law was contested in Quebec. It was upheld, which was great news. But, laws change over time. So that's something we'll continue to talk to people about. The one thing that I think people forget about is that insurance companies can use family history to determine eligibility for insurance or what your premiums may be. So if you come from a family with a really strong family history of cancer, that in and of itself might still be used in terms of determining your insurance, but that's another conversation. So I just want to say one piece about trust, and I think something that's starting to change and will hopefully build more trust too in terms of genomics is just the idea of transparency, of collaboration, of hearing back from participants. What would you like to know? I think all of that will go a long way to building trust and hopefully having some flexibility, that not everybody's going to want the same thing from genomics, and hopefully involving others in some of the decisions around what we can do with research. So it's not just what's perceived as the ivory tower making that choice. So variant reclassification, switching gears, I'm going to say it depends, because it depends on where that genetic test result is coming from. So in our clinical world, there's examples of these, really big commercial labs that a lot of clinical genetic testing is done at. They test, lots of people every year, and so they're getting lots of variant information. And if they, get enough evidence and data on their end to reclassify a variant, they'll reissue a report back to the ordering clinician, so that it'll say, what, this one's actually now benign, or this one that we didn't know what it was, now it's actually a disease-causing mutation. So that allows us to follow up with families. That may happen 6 months after the initial result, or it may happen years down the road, depending on the variant. One of the important pieces of variant classification, and again, sort of transparency and sharing, is there are some databases that testing labs contribute their variant data into. One of them is called ClinVar. And so what that allows labs to do is pool information, so that eventually, if they can all get to an agreement that this should be reclassified, then that website will be or that database will be updated. Unfortunately, for a lot of us in the clinical realm, we've said to patients, okay, you have this VUS, call us back in a couple of years and we can ask the lab to relook at it. So sometimes it's not something initiated by the testing lab or the research study, it's actually us or the patient asking for someone to go back and look at it if it's a rare VUS. So there's multiple different ways it can happen. Some labs, don't go back unless they see it again. So that's why it could take many years sometimes for a VUS to be reclassified. Other labs might have a team of staff, if they're really well-resourced, to go back every 6 months and take a look and see if there's anything new. So that's not a straightforward answer, but I think it's a complicated topic and depends where the testing's done.
It's a totally complicated subject. And I think, just to say that in my clinical practice, I think I can think of 3 times where I've seen a VUS moved up to a pathogenic mutation. And that's happening less as we understand more about the pathogenesis. So I think it's, although we talk about, we see a lot of VUSs, I think the reality is not very many of them are considered pathogenic. I want to bring in somebody else to make a comment, but one of the things I want to just stress to the audience is what we've been talking about up till now really has been inherited genomics and inheritable mutations. One of the things that was brought up early when Howie was talking was around personalized oncogenomics, and that's really looking at what we call somatic genetics usually in the tumor. So we're looking at the genetics of the tumor, and what's in the tumor. There are many genes in the tumor that have nothing to do with the inherited. So you can have, an inherited genetic mutation is in every cell in your body. Somatic mutation is just in the tumor. And one of the things, I just want to bring this up just so people aren't confused. When Howie was talking initially about the personalized oncogenomics program, what we're finding sometimes is when we analyze the tumor, we find evidence of these inherited genes. And that's when we bring in the hereditary program and everything. And the reason I want to bring this up now is because there is this whole issue of material incidental findings and things like that. And a lot of people worry about, well, why are you even looking if, why are you finding these things if you aren't looking? So with Claudia's story, Howie was looking, she was 33. He said, why does she have colon cancer? She was saying, Howie Lim, are you smart enough to tell me why I have colon cancer? So he was looking for something. But when we're doing the personalized oncogenomics, we're often just looking at the tumor. Now, one of the questions in the chat line is, are there ways the REBs can help promote the process of return of findings? And why I wanted to give this little thing between inherited and somatic findings was because of that overlap. And I want to bring Christy Wester into the conversation now, who is the Director of Research Ethics at the BC Cancer. So Christy, can you address a bit this question of, are there ways that REBs can help promote the process of return of findings?
Sure. Thanks, Caron, for putting me on the spot. I had to put a decent sweater on because I wasn't planning on being on video.
Well, we could be full disclosure, transparency. I did text Christy and tell her I was going to ask her a question.
Science is advancing so fast, and I think it's very hard for research ethics boards to keep up to speed, and particularly when we're bound by so many regulatory requirements and external folks that don't deal hands-on with patients the way I think sometimes with research ethics with what the core was. And so I think what we're trying to do is, again, get back to, I say I'm having issues with my internet here, really getting back to what participants want and what's possible in terms of the science. And education is really key for us, and it's something that our board and our research ethics group really wants to focus on, is how do we educate. And so we get hit with these things about material incidental findings, and there's debate amongst the experts. They don't even use the same terminology when they're talking about those things, and it changes from the US to Canada as well. So those are, some of the basic concepts that we're dealing with. We're not even speaking the same language. So how do we educate ourselves? How do we collaborate and know that we're talking about and we're interpreting things the same way? And I think that was something I was on the earlier morning thing. We were talking about privacy, and privacy issues kept coming up. And one of the core things we have with, I think, privacy is it's all interpreted very differently across provinces, across institutes, across countries. So, and I think that's kind of maybe what we're dealing with in terms of return of results is, what do we return? How can we return it? And also fundamentally, I think one of the things that has sort of been touched on is, do we have the resources to return? And we see that in BC Cancer. We're very lucky in terms of we do have the HCP program. We have many resources available to us, but when you are looking at other areas across Canada, and as Nadine has touched on, geographically isolated areas, they may not have the infrastructure or the resources available to return results or even do testing. And we're seeing that in terms of some of the collaborative projects that we're trying to do when we're working with other institutions. They've come across and said, look, we don't have the resources to return findings, so we're just not going to do that. And then we get into the debate of, is that ethical? Like, how can we approve that from our aspect? Because we don't think that's ethical to invite participants in when we may have the capability to give them that information back, but other institutes may not have those resources. How do we balance that and ensure that the research continues to go ahead? So I think return of results is one of those areas that we really need to start being collaborative, communicate about, and start working together to figure out how we can best do that.
Yeah, I think that's a great answer. And I think just to add on to that, I mean, I think that, we do have resources, but they're not always timely resources. And what you want and what Claudia brought up was timeliness. We want timely resources. I think one of the things that we often talk about from the REB perspective is, what we're trying to do is look after the subjects and that. And one of the things often that I feel wearing both my research and my clinical hat is that the expectation of subjects is that when we're testing something, we're getting all of this information. And therefore, if the subject's expectation is that we're getting this information, then we are bound to give them back this information, because we're really dealing with false expectations if we don't. I think the other big issue that's been brought up by Christy, that's been brought up by Nadine, that's been brought up by others is, equity. We have to have equity in terms of access to the research, access to the genomic testing, access to the resources and the skilled communication that Jennifer has talked about in terms of, giving results, access to all of those things across the board. So I think that Christy's brought up that, we're trying, but, it's dealing across jurisdictions, dealing across things is difficult. One of the other big places we run into this trouble is a lot of the times we're dealing with sponsors, and sponsors may have a totally different view. And we can't just reject all research from sponsors, because then we're not providing research opportunities for persons in our jurisdiction. So, it becomes very difficult. One of the questions that's just come up, and I'm happy for anybody to answer this, is how do we educate or promote sponsors and researchers to think more about diversity and equity in genomic research? So I don't know, Nadine, Sophie, Howie, Christy, any of you might want to take this.
Actually, I was just going to comment something similar was, honestly, I think it's about having researchers or clinicians sit and learn on the REB. And if you look at POG, Sophie and I were on the REB, Dan Renoff is also in POG, who sat in the REB, and you learn so much about these issues by being in the REB, and when you bring that to your research project, you just have that awareness. So that way, when you get something from pharma or other sponsors, you have that lens already, so that when you review the protocol, whether this is something appropriate, then you can bring that back to the sponsor at that point, versus launching it and signing all your contracts and then realizing it later on when we submit it to the REB. You can, because you've gone through that process. The honest truth is the REB is a huge educational process, and having more clinicians go through that, I think that will promote that more.
You don't know what you don't know until you know what you don't know. Yeah. Nadine,
and you forget what you don't know.
Yeah. So Nadine, you wanted to bring in something there?
I agree with Howie, and the other thing, another approach that we've taken within the Indigenous space is at the UBC Center for Excellence in Indigenous Health. We've created this research ethics with Indigenous peoples course. And it's interesting because it's incredibly challenging to get into. There's always a wait list, and there's people from across the country that take it, and our target are those not necessarily university students or faculty or deans, although we've had to turn down deans of different departments that can't get in. We've had to turn down postdocs and doctoral students. Our priority are Indigenous students, and especially those that are out in community. And so then it's because it's this 1 week course that's usually in the reading break in February, or it's just before the school starts in September, so at the end of August. And we bring in community members to build capacity in the communities on research ethics, so that trust that we're talking about, part of it is trust. That someone, like, look at Howie, how could you not trust him, right? And so you trust the researcher, you trust your clinician, but at the same time, part of it is also being like empowered to be able to look at the research project when Howie leaves the room, and you read it and you can understand the language that's being used, and you can look at it and kind of say, something's missing here. And when I was in the research ethics course, they said this and this doesn't quite fit. And so creating that empowerment for people to not only be interested in research and to see the benefit of research and to understand the process of it, but to, even if they're not going to do it, to be able to look at the research proposal that's being brought to their community or to their band office or to the population at hand, whether it might be a friendship center or something, but to be able to read it and kind of go, this sounds great. I have questions, here are my questions. And basically to be able to empower the people that we're working with, so that part of it is trust and part of it is knowledge. And that is a beautiful, beautiful, beautiful union. Those two things together is the safest place to be, I think.
Other people, do you want to come in? That was great. So education, and I think, one of the things we've heard today is about the poor literacy in patients and it getting worse with aging. And, how can we educate researchers? How can we educate sponsors? How can we educate subjects? How can we educate population around this? Claudia, I don't see her right now. Maybe
She had to go.
She had to go. Okay, because I was going to ask her about whether herself as a nurse felt that she was better prepared than others. So I'm not sure if anybody else wants to get into that. I think one of the ways about educating is courses. Obviously, one of the ways of educating is people participating. One of the ways of educating is forums like this, and really just working on this. I also think that what's been brought up today a lot is the patient voice, and the patient voice in terms of understanding what communications needed around this, be it from Indigenous communities, be it from other ethnic groups, be it from patients, be it from different age groups, because I think one of the startling things when you looked at that literacy was the differences in age between younger and older. And certainly I know that that also makes a difference, rural versus urban, age, access to information, all of those sorts of things. So I think education, and Christy brought that up right away. I don't know, Terry, you might want to jump in on that question that I asked Christy about what can REBs do before we end it, because we're almost out of time. But Terry, do you have anything to add about what REBs can do?
Education is one of the big ones, but the working collaboratively, like this, like you said, this forum is one way for, and that's why we wanted to bring people together in this type of forum, as well as not all of the people that are attending here today will be dealing with genetic research in their research ethics boards, and so having that exposure to some of the experts that are here and the questions and the things that are being posed for discussion, I think is a very valuable experience in itself. But there's always more to be done. But on that note, yeah.
And I think that one of the things that I think, I'm really fortunate because I work with great people who are all around this. And one of the things that, certainly working with Christy and the rest of the people in the office and around, I feel really clear about is, a research ethics board is not there to put up barriers. A research ethics board is there to facilitate research. And obviously, we don't want to promote unethical research, but we want to facilitate ethical research and not put up barriers. And if that means educating our board around what are the current norms, educating our board around what's happening in science, educating ourselves about what's happening in science, all of those things are important. Just because we did it that way last year, that's the best reason to change how we're doing it this year, because science evolves. And, we've certainly seen that in the COVID things that Fauci said in March 2020 are all wrong now. And we know that science is constantly evolving, and we also have to be doing that. Yeah. So with that, unless there's any other burning questions, I think this has been a great discussion. I have to really, really thank everyone. I also have to put in another plug that there are a lot of commercial genomics companies out there, and some of them are extremely good, highly recommended, but there's also a lot of shingles up there from people who don't have any genomics expertise. So learning about genomics through validated research programs is really how we have to keep going forward. Thank you, all of the panel. Thank you to Claudia, to Sophie, to Howie, to Jen, to Nadine. I think this has been a great discussion. Thank you, Christy, for putting on a new sweater and coming into the discussion. And thanks to all of the organizers. So I'll let Terry close.
Thank you very much. And she said it all. Thank you to everyone, because as Caron said earlier when she was giving her thanks to Jessica Gagliardi, this was a collaborative effort of this team coming together and going, this is what we think would probably work for this afternoon session. And they worked on it together, came up with their ideas together, and kind of formed this. And we just did the work in the background, trying to get everybody to send in their slides, that kind of thing. So I just want to say thank you, everyone. It has been a very good afternoon. And just to say to all of our attendees here, thank you for sticking with us. It's been a really good day for all of us here for being able to have these 2 long sessions, but we have another one tomorrow. So we have another session tomorrow, which is on innovations in clinical trials and informed consent, which is promising already to be a very good discussion because of the stuff that we were talking about this morning already. We're going to be obviously trying to get everybody's feedback on the session. You will receive an email asking you to fill out a feedback survey at the end of the day tomorrow. It'll come out to the email that you registered with. And anybody that is needing a certificate for educational credits for taking a continuing education, you also be able to access that through the survey completion tomorrow. So I just want to say thank you, everyone, for a wonderful day. Thank you, Caron, for an exceptional job of moderating. Well, good job, and I really appreciate you doing this. And so with that, we'll see you all tomorrow. Thank you very much.